Good morning. Welcome to the May webinar series of Governor Mills Opioid Summit. And we want to welcome Mike Freysinger and Amanda Thompson. This week for May, we have a topic called Intersection of Crisis Response and Substance Use. I am Richard Freund, program manager in the SUD division of the Office of Behavioral Health. Normally we have Gordon Smith here, but he will not be with us today, but he's with us in spirit. And of course, we've got Lorena running the logistics from behind the curtain. She's with Adept. So we're going to have a great discussion today and a great useful topic. So first, I'd like to give a brief bio. Mike Freysinger, the recovery manager for the Maine Office of Behavioral Health. Mike serves as a recovery manager at OBH, a position he has held since 2021. As a recovery manager, Mike oversees peer support services, which include certified intentional peer support and recovery coach training, peer recovery centers, recovery residence certification, and others among his other agreements. Mike also worked closely with OBH's workforce development team and the Cutler Institute's Center for Learning, who support the Department of Behavioral Health training and certification processes. Mike has completed the SIPSIS training and SIPSIS trainer facilitator training and CCAR's Recovery Coach Academy and ethical considerations in recovery coaching. Wonderful stuff. Mike is a person in long-term recovery who has held various roles in direct service, affordable housing, and conflict resolution, most recently working as the director of the Maine Youth Court, a restorative justice juvenile diversion program where he first worked with SIPSIS, who supported youth after they engaged in restorative circles. Amanda, peer crisis training manager, Maine Office of Behavioral Health. She's also a person with lived experience of substance use and mental health challenges and long-term recovery, as I am myself. Her experiences navigating clinical systems, community-based support, and individualized pathways of wellness led her to peer support in 2018 through recovery coaching. Amanda is certified in IPS, which is intentional peer support, and is an IPS trainer. She has also served as a recovery coach trainer. She has provided direct peer support, supervised peer teams, and led peer programs. For the past 2 years, she has worked at Maine's Office of Behavioral Health as the peer crisis training manager, supporting statewide crisis system reform and the integration of peer support roles into Maine's crisis continuum. So based on that, the expertise of my colleagues today, we're going to talk about intersection of crisis response and substance use. We're going to start with Mike giving us sort of a broader overview of the program itself, and then Amanda will follow with a PowerPoint presentation on the details. So Mike, take it away.
Thank you very much for that introduction, Richard. I really appreciate it. And I just want to name that, talking about crisis services today, it's probably not the typical topic at the Opioid Summit webinar series, right? But we know it's really important because mobile crisis services or crisis services more broadly really sort of touch all Mainers. And we know that for a long time, sort of post institutionalization in the 70s, there had been this real push towards specialization of treatment in the way that we thought about mental health and SUD services. And then in the last 15 or 20 years, there's been this new push towards co-occurring competency in the care that we provide for folks. And additionally, Maine's crisis system is on the verge of some really big reform efforts. And so it's really important for us to share those updates and reform efforts with everybody throughout the system of care. And in particular, we're going to do a brief overview of sort of the entirety of the system of care in just a moment, and then we're going to get into some of these new reform efforts and how they specifically touch folks who may be experiencing SUD challenges. Because we know that when we know as providers, as community members, as advocates, when we know more about all of these services, we can work to really fully realize the no wrong door approach for community members seeking care and provide in the moment support that makes good referrals for folks and provides the best care for them. If we can move to the next slide, please. Maine's crisis service in the continuum of crisis service care is really sort of broken down into 3 lines of service. And these 3 lines align with SAMHSA's national guidelines for crisis care. The first is the someone to call. And in Maine, that's the Maine crisis line or 988. I imagine a lot of folks have seen a lot of our marketing efforts to really promote the new 988 number over the last couple of years. In addition to that, there's a couple other resources, the peer support line and the Wabanaki care line run by Wabanaki Public Health and Wellness for all Indigenous folks. Then there's the second bucket, and that's someone to respond. And we're going to talk a lot about that in just a couple of moments. And that's really mobile crisis response teams. And there's a provider that operate these teams in all districts across the state of Maine. And they additionally have some walk-in hours at a couple of locations across the state. And we'll have a slide about that in a little bit. And then there's somewhere to go. Currently, there's the Crisis Receiving Center in Cumberland County, where folks can just walk in and receive crisis services, anybody aged 14 and over. There are 2 new crisis receiving centers being established in just the next couple of months, one near Androscoggin County and one in Penobscot County. And so we really look forward to those coming online. And those really sort of represent those 3 buckets: someone to call, someone to respond, and somewhere to go. Can we go on to the next slide? And we'll just dig in just a little bit deeper about those 3 buckets and how they work. And so, a person experiencing a crisis in the community, we hope that the first step for them is to call one of those crisis lines, primarily 988, the Maine crisis line. And currently, about 80% of those calls are resolved over the phone. And so the person who calls is able to talk to a trained crisis provider on the telephonic line and have their crisis resolved over the phone. The next step, someone to respond, the mobile crisis teams, of those calls that get referred out to the mobile crisis team for response, about 70% of those responses are resolved right in the field. The crisis teams are able to provide a quality intervention and support the person in a way that allows them to remain in community, remain at home. And then from there, the somewhere to go, a even smaller percentage of folks who go to either a crisis receiving center, a crisis stabilization, or crisis residential. About 65% of those folks are discharged back into the community with a support plan and supports in place, and then additionally get follow-up post-crisis wraparound services to support ongoing success in the community. And all these efforts combine to really help prevent contact with law enforcement, having individuals have to go to the emergency department or go to long-term inpatient care. And so you can sort of see the descending levels of care from someone to call, someone to respond, and somewhere to go. If we can move on to the next slide, please. And part of the reason that we wanted to talk to folks today and get this information out is because, as I said earlier, Maine has been working on some upcoming crisis system reform efforts initiated by new SAMHSA guidelines for behavioral health crisis care. Those guidelines were released January of 2025, but there had been a lot of sort of messaging and work done with states ahead of that, the release of those new guidelines. And so Maine has really been working on initiating some of these reform efforts for quite some time. One of the big changes upcoming is that the new guidelines call for a significant role for peer supporters. And so in preparation for that role, the state of Maine has worked on creating a new crisis certification and credential, the Certified Intentional Peer Support Specialist Crisis Service Provider credential. Additionally, updating the training for the sort of existing historical mobile crisis certification, which is the MHRTCSP, Mental Health Rehabilitation Technician Crisis Service Provider. And so both of these trainings, the new credential for the peer support position plus the updated credential for the MHRTCSP, meet these new national guideline standards. As I said earlier, we have gone through a really significant process to create this new training that included some significant stakeholder engagement, including community members who've actually utilized crisis services, providers, and staff at OBH to really learn about their experiences, what they saw as working from the old training curriculum and the old model, and what they saw as gaps and needs. OBH hired a consultant to help develop new curricula, Just and Rainey, who ran significant body of crisis services in Colorado for 10 years, and is also a researcher and author in the field of crisis services. And the new crisis curricula is around 100 hours, sort of all in, depending on the role. The training is asynchronous, on-demand training held by the Cutler Institute. And the new training is going to go live in just a couple of weeks, and the new model will be implemented this summer. Next slide, if you don't mind, Amanda. Thank you.
Next slide is for me.
Oh, well, yeah. Then there you go. Thank you.
Thanks, Mike. So the following slides are about how the new training that Mike was just talking about is going to teach CSPs, crisis service providers, both the peer support CSPs and the MERT CSPs, to approach substance use when they are providing an intervention for participants. And so the new training is built around these core values of crisis support. And again, these values are shared between clinically informed CSPs and peer support CSPs. So first, the core value of avoiding harm and promoting dignity in these interactions. We want support that doesn't cause further harm or disruption in someone's life, that demonstrates respect and compassion for the individual, that's driven by personal choice and self-identified needs. The second value of being person-centered, so understanding and appreciating the uniqueness of each individual's circumstance, allowing people to make decisions for themselves, and supporting those decisions. We want to bring an element of mutual responsibility into these interactions with folks in the community, acknowledging that we have things that we can actually learn from each other, and that there is an element of like sharing and vulnerability in the way that we approach support. We want to negotiate what feels good in these interactions for folks as well. And to establish feelings of personal safety really means supporting the identification of what feels safe and unsafe for people, and really working to increase that felt sense of safety. We want to make sure that interventions are strengths-based and hope-based, which means supporting people to identify and rely on those strengths that they have within themselves, supporting them in finding pathways to navigate their experiences, believing that people can heal and that there are possibilities beyond the experience of crisis, and that people can live the lives that they want to live. We want to make sure that support is trauma-informed and culturally sensitive, so that we understand the importance of people's individual trauma histories and the responses that they have to trauma in their life. That they also have experiences of identity and cultural background and beliefs, and so that our support adapts in ways that appropriately interacts with those experiences that people have in their lives. And the last is that support upholds healing, empowerment, and includes natural supports. So CSPs are not here to necessarily like fix things that are going wrong in the moment, but we're here to support people in expanding their understanding of healing, creating pathways towards that healing. And again, that we leave people in a place of empowerment to live the lives that they want to live. And that means supporting the identification and the reliance on natural supports that folks have. So something to consider when we're thinking about how to provide an intervention for someone is actually to like jump to the end of our time that we would be spending with someone, which is like referrals and follow-ups. And so it's important to know that the referral and follow-up rate for a crisis interaction is fairly low. So very few referrals are followed up on. These are national statistics. It's about 33 to 50% of people will follow up, which means that roughly 70% of participants may never attend an appointment for a referral that's given to them. And so when we do make referrals in crisis interactions, we really want to make sure that they are relevant to the person and relevant to their experience of crisis. And so this often means that we'll make referrals that are going to support ongoing harm reduction needs, connecting people to community supports like groups or meetings or other communities of choice, maybe connecting them to the program like the options liaisons, and in cases where it's appropriate or wanted for someone, helping them connect to medically managed withdrawal support. And so we do know that follow-up contact after an interaction really increases people's felt sense of safety. 90% of high-risk callers reported that just the check-ins really helped to keep them safe. So to stay person-centered and aligned with the core values of crisis support that I just spoke about, and really keeping us focused on like good in the moment support for participants, the new training is going to teach CSPs to understand substance use that in ways that destigmatizes use and helps the CSPs really stay in a space of non-judgmental approaches. And so the way that we are going to teach folks to understand substance use are in these ways. First, that not all substance use is problematic. There is a continuum of use from beneficial, like our morning cup of coffee, caffeine to get us going, or taking medication that's been prescribed in ways that are prescribed, and then across the continuum to things that are labeled as addiction or dependency. We don't want folks to assume that substance use is part of someone's crisis. We want them to self-identify that that is something that is taking place for them, and that the approach to understanding use is that substance use is morally neutral. And so our support needs to come from a non-judgmental place. The reasons that people use substances are deeply personal and often very complex. So again, we're not necessarily having CSPs believe that their job in that moment is to fix anything. These are challenges that people have in varying amounts of time. And so it's not something that can be really fixed or taken care of in a quick interaction. The reasons substance use can also be a comfort strategy or a coping strategy. And so we want to honor that that is a real experience for people. And at the same time, understand that things like withdrawal from alcohol and benzodiazepines can be lethal. And so really holding both of those things at the same time and informing how we are going to support someone. There are also very real challenges that come up in supporting people who are using substances, both from a CSP aspect, but also as a participant or someone receiving this kind of support. Many people believe that support might not be available to them if they are intoxicated, or CSPs might feel uncomfortable in supporting someone who's intoxicated. So the new training teaches interventions that can be provided to someone regardless of intoxication. And that really starts by exploring someone's reason for reaching out and staying very person-centered in that way. Another challenge for participants can often be the fear of contact with systems like the child welfare services. And so again, this training teaches that simply the presence of substances alone in someone's life doesn't necessitate reporting. And another challenge might be that friends, family, community members, onlookers to a situation that's happening in the community, their feelings about someone's substance use might be very different than that of the participant. And so acknowledging that they may also be folks that need support. So the training also teaches support strategies for those that are considered concerned others. So considering what we know about the referral follow-up rate that I mentioned on a couple of previous slides, the goal of crisis interactions is really to provide in-the-moment support. And so connection to long-term treatment isn't necessarily the goal, but support that increases the opportunity for engagement is. And so the new training is going to teach CSPs to basically prepare for what we call a harm reduction only intervention. And this is making sure, again, that we stay really participant-centered by letting the participant identify the harm that they are experiencing and focus on what they would like to explore. And so this might be just introducing them or supporting them in basic components of harm reduction. So sort of our classic, like, go slow and go the way you know, use with someone present, supporting people in identifying a safe drug supply or being able to test substances for contamination or unknown substances, supporting them in meeting their basic needs, which can also include access to safer supplies, overdose support like Narcan. But we really want to meet the person where they're at. And so honoring and respecting where people are in their journey, in their healing, in their life, and having responders let go of expectations or judgments that they may hold in the moment. We recognize that people may not be ready for change, and they don't need to be in order for us to provide support in a crisis interaction. We really want to work with folks to explore what does moving towards, the life that you want to live look like? What are those possibilities? And then connect them to resources if that is desired by the person. But overall, we want people to have an experience that supports them in reaching out again and engaging in follow-up, because relationship actually really is that bridge to longer-term support or longer-term treatment. And just to sort of wrap up here, thinking about like, what are the possibilities of this work and the possibilities of like all of our work sort of coming together here. We are bringing this information forward, like Mike said today, so that we can work together as in different services and different programs. We can also work together in different roles, like clinically informed roles and peer support roles, to best support people in our communities and ensure that we are really operating within that no wrong door philosophy. Really drawing on what we know about the power of peer support and the power of just being with people. What we do in the moment really matters long term. So when we are able to provide interventions to people that really say, we believe in people's capacity for change. We're offering them support that is destigmatizing and is non-judgmental, and giving them opportunities to grow trust and have connection, with people. And again, we're offering our presence, collaboration, and planning, really helping folks identify and then draw on those strengths. This is what results in an experience for somebody who is having a really, really bad time, circling back for that ongoing support and staying connected with these services more longer term. Just a final slide with some contact information with some of our team members at OBH. If there are other questions, Bree and Patrick are sort of the main points of contact for any ongoing questions or conversation. Thank you.
Well, thank you so much, Amanda and Mike. There definitely are a couple of questions, but before we get to those, I just wanted to circle back for a second. We talked about this training. What other trainings, and I think in the first slide, you might have shown the other qualifications that a crisis team member might have, but what other trainings would be useful or work parallel? Like, would it be CCAR? Would it be, what's the rounded out training going to be like for one of these folks?
So for the peer support role, folks have to have completed the SIPS training and worked as a SIPS certified intentional peer support specialist role for 1 year. So they have to hold that certification and have worked in a role in direct service with that certification for 1 year. Then they can sign up to take the SIPS CSP training, which is the first block we call Crisis Core. And regardless of your role, whether you're a MERT CSP or a SIP CSP, everybody has to take that same foundational Crisis Core training. And a lot of it is sort of like sort of background in crisis, how do people experience crisis, crisis theory. Then they take a role-specific CSP training for the clinical track for the MERT CSP and a peer track for the SIPS CSP. And that's the training for their provisional CSP training. And then they take a micro badge training for the mobile response. And we're developing micro badge training for telephonic as well. And we hope in the future we'll be able to add some additional micro badge trainings for other areas of the crisis continuum of care. And one of the things I really appreciate about the way that the training design sort of came to be over the last couple of years of design work is that, again, everybody gets that same foundational training, regardless of whether you are the MERT CSP coming from this sort of clinical perspective or the SIP CSP coming from the perspective of an individual with lived experience in that peer practice. Everybody receives the same foundational crisis training. Again, that crisis theory training serves as the foundation for how this service is delivered in the community, which is really wonderful.
Yeah, it's excellent. And it really is an example of bringing all four pillars together in a moment in front of, two people helping each other, one person helping another in a service role. The idea of prevention, treatment, harm reduction, recovery support. And depending on the exact circumstance, like one of the slides said, it's more of a harm reduction situation in general terms, not necessarily in the specifics of what we might call secondary prevention. But is there an opportunity ever to get a little deeper with somebody? For example, on SAMHSA has a website with some definitions of recovery, and they talk about what recovery is, and there's no mention of substances in that definition. Is there an opportunity to get to that place with a participant or a citizen at the moment of discussing recovery as a evolutionary path or dimensions of wellness? Do we get that chance in this work, or is that a later referral?
I think it really depends on what is happening for the person in the moment. So certainly there will be, folks who are receiving that crisis support, that are interested in having those conversations, especially where we're going to have peer supporters, doing some of this work too, and so can speak to like their lived experience, maybe how they like initiated some change in their lives. Like for sure, that is that opportunity is there, and because the experience of crisis just varies so much for people. It can be actually really disconnecting to sort of get into conversations that are more like recovery oriented if that's just not the place that somebody is in the moment. So this is another piece that the new training sort of really holds, like how do we know when somebody might be ready to have that conversation? So we spend a lot of time in the training sort of considering different aspects of people's lived experience, different sort of pathways of wellness, how to engage in conversations where we are able to really stay connected to the person, really stay participant centered in those interactions, and sort of like feel it out and see what they might be interested in without sort of coming from an angle that might feel like really pushy, because what we don't want to have happen in that moment is like disconnecting from that in the moment support, because then we really lose opportunities to continue to like follow up with folks. That's another really important piece of that follow-up that I mentioned. In the moment while you're experiencing crisis, you may not be in the space to have a conversation about what you're moving towards, what's available down the road. So again, if we can provide an intervention in that moment that really like holds some space just to be supported in what feels like the most pressing and current circumstances, and then connecting with somebody the next day, 24 hours later, again, 48 hours later, maybe a couple of days out, that is where we get to like really maintain that connection, continue to build relationship and rapport, and then perhaps get to those conversations a little bit down the road in ways that feel more accessible for people instead of right in that moment of like heightened,
Moment of crisis.
distress. Yeah, moment of crisis. Yeah.
Thanks. There are a bunch of questions. Let's see. First one is, what is the demographic breakdown of folks benefiting from the crisis service continuum?
I'm not sure we have that with us today. We do have a lot of fabulous data on Maine's crisis services, particularly over the last couple of years. OBH has done a really incredible job bolstering our data collection efforts, and we've got some really fabulous folks in our data team who work specifically on crisis work. And so I can certainly ask and see if that's something that we can provide as follow-up to the webinar.
Okay. And Nikki Merrill asked, well, she's commented first, this is so important. Thank you so much. What does or what will oversight look like for 911 sending calls to the crisis line? How do you file a grievance if 911 showed neglect in this?
So that's such a great question. What we have, I'm going to talk a little bit about sort of like what we have seen over the last couple of years, and then some of those expectations moving forward under this new model. I think part of, as you heard me say earlier, right, that a lot of these services are really intentionally designed to reduce contact with law enforcement and reduce hospitalization, other inpatient care, right? There's a huge focus on providing an intervention within the least restrictive means possible. We really want to keep folks in their community for a number of reasons, but primarily we just know that folks do better in their community and closer to home. And so over the last couple of years, we have seen programs to that end sort of bubble up really organically. We've seen a number of municipalities and many county sheriff's departments hire behavioral health liaisons. And that just comes down to their own recognition of the need for treating folks sort of behavioral health first and sort of criminalizing that behavior second. And so some of that has really come up very organically in response to the need that folks are observing in the community. And many of those programs are very successful. And the expectation under this new model is very overtly to continue to seek opportunities to divert from law enforcement contact. And under the excuse me, under the new model, providers are mandated to maintain partnerships with local police departments. And so the role for police, if and when 911 is called and law enforcement must be dispatched because of mandates, the job of law enforcement will really be to clear scene safety, right? And so just make sure that the environment is safe and mobile crisis responders. And so 911 will sort of call in the mobile crisis response through the main crisis line and ensure that mobile responders come. The police will clear for scene safety, and then we can move into our normative intervention through this new model after that. And so really thoughtful partnerships and delineation of role and responsibility under the new model. And Nikki, I hope I answered your question. As far as a grievance, I don't know of any process for that.
Thank you, Mike. Another comment is, will the vision of this be available on an organizational chart? I'm a visual learner, so just think about that for a minute. And Katie White's question, how is the department intentionally engaging with homeless services agencies, in particular low barrier providers in Portland, Waterville, and Bangor? Many of the most acute cases in the community are with people who lack housing, yet the system rarely takes into account the barriers lack of housing causes access to care. And unhoused folks are dramatically more likely to have died from overdose than people who are housed. I know my staff in Waterville would welcome training and collaboration.
Yeah, Katie, that's a really great question. And so I know, the current providers of mobile crisis service are really well tied in the community and offer a multitude of services, right? And as you heard Amanda talk about earlier, the in the moment crisis intervention is really about making sure somebody is like safe enough for tonight and has a strong connection, feels connected, gets some validation, has a plan, and engages them enough, builds that relationship so that they will take advantage of the follow-up, the aftercare that is, again, it's mandated through contract and it's part of the model. And so that follow-up can be led to, connection to maybe an options liaison, other outreach programs, services, traditional behavioral health services, OHH, BHH, CCBHC. And if you want to talk about it further about sort of like a particular community getting connected and building some bridges, I will make sure that my contact information goes into the chat in just a moment. And so I can learn more about what you're experiencing in your local community.
Thank you, Mike. Next question is, will CIPPS professionals who are not working specifically in crisis roles be able to take training on crisis theory or other crisis-related content as part of their ongoing CIPSIS certification requirements?
So yes, people who hold a CIPS certification will be able to take the crisis training. It isn't going to sort of count. I'm wondering if this person who's asking this question is a CIPS certified person. So it won't necessarily count for your like continuing ed needs, but you will have access to it. And then you can decide to work in crisis services or not, but you would have access to it.
Thanks, Amanda. Next one, Mike, will the micro badge trainings be open for others not working for an agency with crisis contract? For example, for liaisons working with police departments employed by a county options model or employed by a municipality like Portland.
No, not at first. To get into the micro badge training, somebody has to be working in a program that holds the mobile crisis modality through their licensing and is working under a contract to deliver mobile crisis services. We absolutely are going to explore broadening that in the future. But our primary focus right now is a successful launch of the new model and the new training certificate. We've heard from a number of sort of crisis adjacent staff across the state as we've been sort of promoting this new model. There's a lot of excitement for folks to sort of continue to build their skills. And we know that there are a number of service providers who have some crisis adjacent staff that they think would really benefit. And so that's definitely on the horizon and a thing that we just need to give more thought to as to how we want to roll that out and how we would sort of manage and oversee that.
Thank you. A couple of comments in the chat worth mentioning. Catherine Sanders, to the comment on the visual learning question, we would love to work with OVH to get CSP tracks up on the website, which is www.rbhwc.org for both SIPS and MHRT. So they have a contact number there. And another comment is, with the closure of Inland Hospital, we have no referral agencies. This raises another point about services and balance of state as healthcare faces significant constraints and service elimination. Does that spark any comment from you guys?
I mean, just some empathy from me, right? We know over the last maybe decade or more, there's been a consolidation of a number of hospitals across the state, particularly in some of our more rural counties. And we understand that makes it really, really challenging to meet the needs of folks in your community. I think one opportunity we have here with the mobile crisis is that they show up to where folks are currently and provide not just that in the moment crisis intervention, but that really, really important aftercare.
Yeah, exactly. Thanks, Mike. We have another question and answer from Edie Smith. Good to see you, Edie, or know you're here. And she's commenting, I would think our options liaisons around the state would be an integral partner. Are they being integrated into the training and program development? Thank you for this very helpful information.
So we consulted very closely with our SUD team here at OBH in a number of the elements that will show up in the new curricula to make sure that we were sort of hitting all the marks. We've been having some conversations, and I saw another question about sort of evaluation police community response liaisons, right? And so we know that there are like police behavioral health co-responders, there are options liaisons, and now mobile crisis has this really purposeful inclusion of SUD and harm reduction considerations, both like individual modules in the training as well as like a thread throughout the training, the new curriculum, right? And so some of the things that we've been talking about here in the office is really getting some clarity on the distinct role for all three of these, right? The police behavioral health liaisons, the options liaisons, and the mobile crisis response workers. We want to make sure, A, that they are all working in unison, right? We want to try to minimize that overlap. We want everybody to feel confident in both knowing their role and executing with fidelity. And so we imagine shortly after the launch of the new model, having some of those conversations with Ernest in a really thoughtful way.
Thank you, Mike. With all this talk, let's get a little more specific about the logistics of the training, the launch, sort of who, what, when, where, why. Like, when is it going to start? How will it be starting? A little bit more of the specific launch of it.
I may not be able to dive into as much detail as you might like, Richard, as the Mobile Crisis Services is currently in the competitive procurement process. And so while it's in that process, I'm not, there are some things I simply can't share. But again, the launch for both the curricula and the new model are this summer. And Maine, again, has undergone some significant updates to the Maine care policy with the recent launch of Section 66. And so folks can look to the recently updated Maine care policy, Section 66, to find some details on that. Sorry, I can't help but sort of
I'll
have my
read it.
attention drawn to thank you, Richard, right? The comment pops up and I'm like, ooh, what's somebody asking?
I got that.
Yeah. Oh, that's a really, do you mind if I respond to that
No,
question
please, if you caught
from
it.
Andrew?
Yeah.
That's a good one. And so um, as the model is designed, once the determination is made at the main crisis line to dispatch mobile crisis response, the caller on the main crisis line informs the participant that we've got both of these roles, and which would and gives a little bit of explanation about their two sort of backgrounds and specialties, right? One being a clinically informed MERT CSP, one being informed by lived experience in the SIPS CSP, and asks, who would you like to have sort of make primary contact with you when they arrive on scene? And so really, again, going back to that sort of person-centered, we explain what the two roles are, and we ask, who would you like to have sort of, make that primary contact? And then once they're on site, whoever is in the role of sort of primary contact initially, the other staff supports what we call sort of just some environmental management work. And so if it's at a house, if there's anybody else present, or if there are pets around to make sure that it is a safe environment. And then depending on how the active intervention plays out, they may switch back and forth between their roles based on the needs or desires of the participant, information shared during that experience. And they are really they are part of a team with the sort of singular goal of providing a successful intervention in the community with a priority on using the least restrictive intervention possible and helping keep this person in their community as much as possible. Andrew, I hope I did a good job answering your question.
Well, one of the pieces to that question too is that the training that we have developed for both the MERT CSPs and the SIP CSPs teaches these two roles how to work together in partnership. How to really like do the work in a way that tries to keep the power between the two roles like in an equal spot. So both a clinically informed intervention and a peer support or lived experience informed intervention are seen as having equal value to the participant, being supported. And so that's one of the from where I sit doing the peer support work is one of the coolest things I think about this new model. I wanted to note too that when we're talking about mobile crisis services, when the MERT CSP and the SIP CSP go out together, we are using the language of a dual response model because we do know that the language of co-response often points to law enforcement being involved in that interaction. It's a law enforcement officer and somebody else, the behavioral health liaison, right? Like Mike was saying. And so we're intentional about using the language of dual response model to show that these two people are crisis service responders. One of them is not law enforcement. It is set apart and different than like a co-response model that would include law enforcement.
Right. Which is the way it's articulated for the options liaisons, right? It's the essence of that was as a co-response with the law enforcement to join on an overdose call or something like that. Catherine Sanders has put a question in. Dartmouth Health is launching an Echo for first responders as part of their HRSA project, bringing together some of the strands discussed here for practitioners in Maine, New Hampshire, and Vermont. And would this be appropriate to share with the group?
Maybe, Catherine. I copied the link, and I'll certainly follow up and check it out. And again, I put my email address in the chat, and so if you want to reach out directly and connect online so that I can learn more and share more, I would really appreciate that. And then I saw a comment in the chat that I think, about considering the inclusion of syringe service providers. And at least as it stands currently, the current mobile providers, many of them are, or some of them are active licensed syringe exchange programs. Some of them also provide the options program in the community. And so again, the service is currently being RFP'd, and we don't know exactly what that landscape is going to look like after that process has concluded. But certainly we will. It's a requirement as part of the contract to receive training in administering naloxone, bringing naloxone with you, and referrals to appropriate services, including harm syringe services, as part of that broader harm reduction strategy in the moment.
Thank you, Mike.
Thank you.
Let's see. Is this a new one? Thank you for this presentation, and this is from Ann Seitz. Thank you for this presentation. I very much appreciate the emphasis on harm reduction. Please also consider including syringe service providers. Did we do that one already? As syringe service providers as part of the community harm reduction network and essential to access for sterile syringes and equipment. So thank you for that comment. Michael, can you reshare your email? Disappeared from the chat. You did that. I think we're caught up. Let's read through. You know, one of the things we talked about when we first discussing this topic, Mike and Amanda, was, you know, that idea, like you were just pointing out, it's a dual response, not a co-response. But how do we, how do you think the training or the lived experience with co-occurring competency comes into play most frequently? Like, is that what we're going to likely be seeing the most of while we're just, you know, assuring people's safety? It's the co-occurring, assessing what's co-occurring in the situation. How do you think that's going to occur?
I think the training really emphasizes, you know, that to stay participant-centered means really letting people define what their experience of crisis is. And so the training overall really boosts or sort of amplifies like co-occurring capabilities in the crisis service providers, the people that are going out to provide the intervention to people. You know, it's sort of woven throughout the curriculum. And at the same time, sort of circling back to some of the slides that I had up, you know, if we were sort of on site in someone's home and we notice like the presence of substances, we still don't want to assume that that's part of the person's experience of crisis. And so it's kind of really like riding this line of like knowing what we know through our training for peer supporters, knowing what we know through our lived experience, and still keeping the emphasis of the intervention and the support really on how the person identifies the experience of crisis and what they are looking for support in those moments. So, you know, even if, you know, in some situations, it might be really obvious to some people that like substances are playing a role in this. If the person is not in that space, then we might not sort of address that. They may be going in a different direction of what they're looking for, you know, for in the moment support. And so we would honor that and, you know, and do that with them, provide that support with them, to them.
Excellent.
And
Thanks,
as I said very early, Richard, right? We know that sort of like post deinstitutionalization, there was a lot of work towards sort of specialization of service delivery, right? And so what we ended up with was this bifurcated service delivery system with sort of mental health over here and SUD over here. And then for the last 15 or 20 years, there's been a lot of work both in Maine and nationally to sort of bring those back together to co-occurring competency. And we still got a lot of work to do, right? And so folks who maybe get trained primarily through a mental health lens in mobile crisis and in just sort of community-based support might all of a sudden discover that somebody that they're working with in a service relationship has some SUD challenges going on with them, and they may think like, oh, that's not my area of expertise. I've got to refer it to the expert, right? And the same thing happens on the SUD side, right? We see folks primarily trained and licensed in SUD service delivery with folks they're working with, all of a sudden some mental health challenges become emergent and they may think, oh, that's not really my area of expertise. I've got to refer that to the expert. And then folks end up sort of being this sort of ping pong ball in our system of care. And so, SAMHSA was really clear about the need for this new model holding that co-occurring capability so that folks have all of their needs met in the moment of crisis. And I think to a really significant level, just the inclusion of peer supporters in that really goes a long way. And then for those clinically informed folks, providing a level of training that gives them the confidence to sort of recognize and delineate how substances are showing up in a person's life in that moment of crisis really allows them to stay with that person in that moment, focus on the relationship, focus on that community-based intervention, and try to get them safe enough for that night so that we can do some quality aftercare and really meet those more sort of long-term needs.
Yeah, exactly. Thanks, Mike. All right, we're coming close to concluding. Amanda, do you have any final thoughts you want to share with those of us in the state of Maine about this project? Or Mike, you've been sharing. We have a couple minutes left for some thoughts.
Yeah, I think I just feel really excited again from where I sit, sort of doing peer support work for a number of peers and training folks about the opportunity that comes with this like new crisis work, a new credential for peer supporters, a new curriculum, and a new area of like providing services to people in the community that's also still like very much based in our like lived experiences. I don't know a lot of people who've really struggled with mental health or substances that would say I've never had a moment that I would label as crisis. And so I think we're very used to in peer support services like meeting people in these moments sort of like unofficially. And so to be able to have opportunities to really like be part of broader services to bring like support that's rooted in lived experience is just super cool to me. I'm just really excited to be part of it and see it grow and be available to people in our communities.
And we're very grateful for that, for you, Amanda. Real quick, Mike, can you answer that one question that came up in the chat?
I am trying to open my document that has that, but unfortunately my computer is being wicked slow. It's just like refusing to. I have like 25 things
So
open.
we can follow up with the response to that, and some people would like all the slides, but we'll follow up as we normally do, and this will be posted on the website. But I want to thank our team today, Mike and Amanda. It's been an excellent talk, very useful information, very exciting that we're expanding services in the community. It's always good to see that. And like you, I have a special place in my heart for peers and peer work and recovery services in general. So it's really nice to be part of this conversation today. I just want to remind everybody that the next webinar will be June 5th, and we'll be talking with, I think, Catherine Ryder about Black Balloon Day. So that will be Friday, first Friday in June, June 5th, 11:30. And then by then it'll be 1 month till the summit, which is July 16th in Bangor, Thursday, July 16th. So we're all excited about that. We've got a record number of breakout sessions planned and some special events as it's the 8th and final Governor Mills Opioid Summit. So put that on your calendars. And, we will welcome back Gordon next month. And that will conclude today's webinar. Thank you, everybody. Thank you, Mike and Amanda. Thanks, Lorena. And we'll see you next month. Bye.